Hello again, and welcome to another podcast of NCI Works. It's Getting to Work, and I'm John Spencer from Starved Rock Media. Our special guest today is an expert in many things healthcare, rural healthcare in particular. Say hi to Pat Schou. Hi, Pat.
Hi, John. Thank you for inviting me on today. I look forward to our conversation.
Pat is the Executive Director of the Illinois Critical Access Hospital Network, the Chief Officer for the Illinois Rural Community Care Organization, a past President of Rural Health Association, and Pat, you really started in healthcare at the ground level, right?
Correct. Yes. I started as an intensive care nurse just out of college and worked in Sioux City, Iowa. And then my husband and I moved here to Princeton. And so we've been in the city of Princeton, which is not too far from where you are, John, and been here some 40 years. And so we love the community, and originally from about an hour north of here in DeKalb County. So it was kind of coming home, and had a chance to work locally, and started as a staff nurse and worked as a supervisor, then eventually became assistant administrator, and we can talk more about other experiences I've had.
Yeah, you really have seen healthcare literally, as I mentioned, from the ground up, starting as a nurse and working through hospital administration, and now working on the side of helping hospitals as an organization with ICANN. Can you talk
Right.
just a little bit about that?
Yes, I'm happy to. Back in 1999, I had a chance to work for the State Department of Public Health, Center for Rural Health, and set up a brand new program for rural hospitals, and that's called the Critical Access Hospital Program. And it was a new Medicare program for rural community hospitals to convert to maintain 25 beds or less and have an average length of stay of 4. And in turn, they got cost-based reimbursement, which helped level their financial balance in their workings. And so that was very important. And I helped convert 52 hospitals over the last several years to critical access status. And that's really, like I said, stabilized their organization and their community. And early in the conversion process, when I worked for the state, back in early 2003 and 2004, the hospitals, we were working together. They wanted to form their own business organization, and they called it the Illinois Critical Access Hospital Network. And I moved over from the state to then manage this new organization.
Okay, so that kind of brings us up to today.
20 years.
And really, sort of what brings us to this podcast today is to talk about healthcare, particularly rural healthcare, as much of our region is rural. You're in Princeton, I'm in Oglesby, and here in the LaSalle, Peru area, at least, and anyone who's familiar with it, a very serious situation with a hospital that has actually closed and is trying to reopen as, well, something other than a full hospital. And we can get into all sorts of particulars and specifics. But at the end of the day, I think what we want to talk about is the crisis itself, maybe how we got here, how this isn't the first time we've been here, and that there are solutions that are being worked toward as we speak, Pat.
Correct. Back in the early 1999, 2000, they created this critical access program because in the 90s, there were a number of hospital closures. It was very serious. They had gone to a new payment program for Medicare, and it was more volume related. And so they knew rural hospitals could not survive. We're at that crisis again, another some 20 years later, when we know that those hospitals that were not able to become critical access, like St. Margaret's and Illinois Valley Community Hospital, what they call tweeners, and they're being financially strapped because of the reimbursement programs that we have, and that's because of volume and increased costs. We just finished COVID, where there was a lot of agency cost, which was, unexpected, and it really, challenges. And, they have increased utility costs and changing programs and hard to recruit people. And so we're back in that same dilemma. So about 2 years ago, Congress passed a new hospital program, which called the Rural Emergency Hospital Program. And it's strictly an emergency department with outpatient services. You can have a skilled nursing unit, but it's an outpatient service. That's a little different than the critical access, and then that the critical access can maintain 25 beds of inpatient services. But the new program will allow St. Margaret's or IVCH or whatever to reopen it in that capacity so they can have a strong emergency department, strong outpatient services around them, and so forth. But the challenge is it doesn't happen immediately because it's a new program, and the state had to create a new licensure with the help of the Illinois Hospital Association. They got that license category created in January of this year. Medicare opened up the payment program in January of this year, and now the state has to build rules so that the hospital can apply to make sure that it's safe and it's got the staffing they need and the programs are in place. And so that'll happen over the next 3 to maybe 5 months, and that should help make a difference for that community.
And we, being here in the immediate Illinois Valley area, LaSalle, Peru, Oglesby, Spring Valley, see this, and I guess it's kind of before us for the trees thing, and you can bring us some outside perspective, Pat. This isn't just a local thing here, is it?
No. It's happening across the country, and particularly we're seeing it, in areas where there's financial challenges. You don't have the business in the industry, or they haven't been able to recruit healthcare workers. We're really experiencing a crisis. And what I mean by crisis, and the fact the amount of money we've had to pay for nurses or lab technicians, it's 3 times the normal cost, and that's unsustainable. So there are hospitals looking at closure in other parts of the country because of that. So our area is not unique. The other challenging thing, which I think has probably hit home for a number of people, is the OB crisis. And back in 1999, when I started working with Illinois in rural hospitals, converting them to critical access, out of the 52 critical access hospitals today, there were 25 of them providing OB care throughout the state. Now, these are hospitals from Metropolis, the bottom of the state, to the top of the state, which is in Galena, from, over by Carthage all the way over to Lawrence County. So they're peppered throughout the state. So now we only have 5.
Wow.
And there also, I don't count for a little bit larger hospitals that might have 25, 50 beds. Many of those have closed, particularly like in Danville recently and Greenville and some of those other areas. And so that's the challenge that IVCH and St. Margaret's is closed, is because of the OB crisis is creating some of that. If I look back 20 years, and I've been in healthcare a while, when I first came to Princeton, Illinois, that hospital, Perry Memorial, which is now St. Clair, they were delivering 500 babies a year. They had to close their OB department 4 years ago because they were down to 125 babies. So I think that's some of the problems that we've had there. And the other issue is that we don't have the babies in our rural communities as much because farming and other industries have changed, but it's become more of a litigious society, the cost of insurance. And if you have any claims, you also have to have a number of babies to keep staff trained. And probably the most important factor that we're dealing with is the cost of delivering the baby. And hospitals can't sustain that. Now in Illinois and across the country, more than 50% of the babies born are Medicaid. And so Medicaid does not reimburse as well as insurances. And so if your business is mostly Medicaid and they're not paying even your cost, it's very hard for a hospital and for the medical providers to stay open, and you have to have enough volume to compensate enough commercial. And that's some of the challenges. And so I've been working with the Illinois Rural Health Association, Hospital Association, Illinois Association of Medicaid Health Plans, which is, Medicaid, and universities, and looking at what might we do besides, just dealing with the crisis, what are some options for us? And I know other states and nationally, the government's looking at that. We're looking at how can we maybe regionalize our OB services? Are there rural hospitals that had to close? Can we get some special funding, some special programs that might be able to open up and support that way? Because, we really want to have safe and healthy deliveries. And so that's very important. And so it's a crisis right now, and we have to begin to look solutions. I know Senator Durbin and others are looking at legislation that could potentially help that.
Great. It's great to hear that people like you, and then even above you, you mentioned Senator Durbin, are aware of the situation and are concerned about it and are working toward possible solutions.
Yeah, the challenge is the biggest challenge, along with it being, money, is that it takes time to put these programs in place. It takes time to pass legislation if you have to create new models of care, like we did with the rural emergency hospital model a couple years ago. Just think that passed 2 years ago, and it took 2 years to get it implemented. So, when you try to solve problems, they're sometimes not immediate fix. Then you have to work with the universities and help train more doctors to deliver babies, advance certified nurse midwives, those things like that have to take place. But the beauty of it, at least there's people now trying to resolve some of these issues.
And I've even heard talk on our local level of getting the firefighters, EMT, and police, those first responders, more training in
Correct.
childbirth and that sort of thing to help people get where they need to get the services that they need.
That's right. And some of the people are resolving their own situation, as say if they have to go another hour or more. We used to have to go 15, 20 miles to deliver baby. Now it's 45 to an hour in many places. And so they're either working locally, like you mentioned, with local emergency responders, but some of the moms are choosing to go a week or two before delivery and stay in a community, a hotel or with family, so they can be there. And so we don't want to have to do. That's why that's a short-term solution, but a long-term is what we just spoke about. But these hospitals and communities, they're doing other things temporarily. They're making sure that they're ready in their emergency departments. They're doing training. All our emergency departments are set up to be able to do a delivery in the emergency room, or even the parking lot. Sometimes that happens, and training staff to do that and care for the baby. So those are temporary things. There's training courses for rural communities to help them. They passed last year additional funding through Medicaid, and I think nationally Medicare has supported it for their disability, is to have postnatal care up to a year, included, to help with some of those things. So they are looking at our rural areas, but it's so acute because it's close to home. And we all have to be part of the solution.
Talking about rural care and how we may have to go a little further for some of the cares that we're used to having right here. I think more than anything, concern is maybe that the quality of care overall that we get in this smaller area is not what you can get in a larger area. What do you say to that?
And that's where I'll disagree with you.
Right.
We believe that the care in our communities are very safe and it's quality. We all, the practitioners, they all go to the same schools as larger institutions. We have the acute care hospitals, like in our area, we have obviously we have St. Margaret's, we have Ottawa, we have Mendota, Princeton, Streeter, all of them. We have rules and guidelines put together by the Department of Public Health that we have to offer and provide services for. And we do a lot of quality controls. The one thing I can say is in our emergency departments, you will be seen right away, where if you go to a large tertiary care center, you may have to wait an hour or two. But I will say that our quality of care is very good. We have emergency room physicians or practitioners trained, ready to take care of you. And we didn't always have that 20 some years ago before critical access. Many of our hospitals didn't have emergency physicians staffed right away. Now with critical access and now with the rural emergency hospital, that will be apparent because access to care is important. Now, you may need specialty care. We don't have specialty care as much in our rural areas. And that may be the difference. Some areas don't have a surgeon 24/7, or they might not have orthopedic services, or they might not have a cardiologist. But many of these hospitals are built in specialty clinics, and then telemedicine allows us to do that. Transferring for strokes and cardiac care, we can get somebody in in a heartbeat. The ambulance picks them, comes in the emergency department. They can treat them with TPA and send them in, and they can have a cardiac intervention, and people are well. So I don't worry about the quality of care. I just worry about being able to support us. We have had some challenges from COVID because of the ability to transfer right away to a facility, because the larger facilities have had staffing issues and bed issues. So our rural hospitals have been able to very well take care of the patients locally and stabilize them in our emergency department until transfer. So don't worry out there. We're ready to take good care of you.
Great. Pat, you seem, despite all of the challenges, you seem hopeful.
I am, because, we have many people across the country dedicated to supporting us in policy and listening to us. They realized during COVID how important our rural hospitals were and that people needed access. We also know that our rural communities are the backbone of this country. Your food supplies, your natural resources, travel, 85% of the country is still rural. And even though, we are dominated by larger cities because of the population, people have to travel, they vacation in our rural communities. So it's very in our food, like I said, agriculture, our food costs are reasonable because of our rural communities. So we have to have the infrastructure so that we can sustain our rural communities, so all these things can happen. So that's very important. And so I think our policymakers and our communities realize that value. And if John, you and I are going to continue to live there, we have to be strong supporters of our community's healthcare programs.
What can we do as residents in a rural community to help be supportive and help move this change along?
Well, I think you have to just simply support your community. If go to your local physician. If you need to have a specialist, that's fine, but you don't have to drive past your local community. Also, take advantage of health promotion and health prevention activities. Be healthy yourself. Our communities have a lot of exercise programs. They all have dietitians that you can work with. They have support groups. I know in this Illinois Valley area, we've done a lot of work with substance use disorders, RUCA, I know Perfectly Flawed, a lot of those support systems. So you as a community person can volunteer to help those support programs and lead those efforts in community-wise. So that's how you can do that. Be supportive, be positive, take advantage of healthcare opportunities, and then support those programs around us that help people that can't, that have mental health or behavioral health concerns, or struggle getting to a doctor. Maybe you can pick them up and take them. Those are things that we can do.
Okay. Sounds like patience is what you're preaching, for one thing.
Yeah, patience, both ways.
Right, exactly. However you spell it, right?
That's right.
Yeah, and then remaining hopeful and positive. Pat, thank you so much for your time today. If someone's interested in reaching out to you for more information, what's the best way to get in contact?
You can contact the Illinois Critical Access Hospital Network. It's located in Princeton, Illinois, just across, not too far from everybody. And that number is 815-875-2999. That's 815-875-2999. And my email is pschou@ican.org. That's pschou@ican.org. And I'm happy to answer any questions. And, we really have to put forth our best effort because we live here. We want the best for our community so that we stay strong for our future and our children that will be there.
Absolutely. Thanks again, Pat, for your time. You've shed a lot of light on what is a very complex and very difficult and emotional thing.
Absolutely.
Many, many people in our rural communities.
There are resources out there and people just have to reach out and take advantage of them, and we'll make it happen. So thank you, John, for the invitation to be with you today.
Pleasure meeting you, and thanks for all you're doing to help resolve these crises in our area, Pat, and across the country for that matter.
Thank you.
Pat Schou from ICANN and the Illinois Rural Community Care Organization. Great guest, and hopefully providing some hope and inspiration for future of rural healthcare as we navigate these choppy waters. That's this edition of Getting to Work, the podcast of NCI Works, for all things work related in North Central Illinois. Go to nciworks.org.